Well, good afternoon. Thank you all so much for coming. Welcome to our panel presentation. This talk is on palliative care, support for the cure, comfort at the end of life, and everything in between. I'm pleased to introduce our two presenters this afternoon. We have Dr. Robert Bergamini, and he's a pediatric hematologist oncologist and is at Mercy Health's ministry level medical director for palliative care. He was appointed in 2013 to the Supportive Care Coalition's Board of Directors and is a member of the Coalition's Executive Committee. Dr. Bergamini and his team established the first support group in the St. Louis area for siblings of children with cancer and an educational support and intervention program to provide supplemental educational assistance and diagnostic testing. And we also have Dr. Jared Bryson with us, and he has served the past 20 years in Retreat Ministries, spiritual direction, parish and seminary education, and healthcare ministry as both a chaplain and mission executive. Jared currently ministers as the Vice President of Mission for Mercy Health and serves on the board of the Marinist Retreat and Conference Center. He is a married father of two and is a parishioner at St. Simon the Apostle Parish. All right, and if you can please join me in welcoming our presenters.
Thank you. This has been a leap for me to go from the world of children and children with cancer to a broader world of adults and children. It's been a very different but rewarding experience. If we could roll back time to when palliative care started to come into existence as a specific specialty, we would choose a different name. There's a great deal of misunderstanding about what palliative care is, and that's what I hope to dispel in this presentation. Bottom line, palliative care is supportive care. It's supportive care for anyone with serious illness. No superscript, no subscript, serious illness. If it's an illness that can be cured, palliative care can be given concurrent with curative therapy. If it is an ultimately life-limiting illness that's going to go on over 5 or 10 years, palliative care can still be involved. And then palliative care is also involved at the end of life. It is not hospice. Hospice is a distinct, defined service. And I'll talk about that in a little bit. So this is from the Pew Research Group, and it was a survey of the general public as to whether or not anybody knew anything about palliative care. And 78% of the American public has no idea what palliative care is. You could substitute medical professionals for American public, and the statistics would be the same or worse. It is a very misunderstood specialty, but one that is coming more and more to the forefront of treatment with many different disease states. So historically, this palliative care developed as a field as a result of a report from the Institute of Medicine back in the early 90s. And it talked about how poorly we were doing providing supportive care in oncology, for people with respiratory disease and cardiac disease. And so that kind of started the ball rolling for palliative care. It became a graduate medical education recognized specialty where you could become board certified in it in 2006. Unfortunately, the Institute of Medicine, as a national organization, continues to focus their attention at the end of life. Although our goal in palliative care is to really extend this beyond. The greatest needs right now are for people at the end of life. But if you were to look at a motto for palliative care in general, it's living well with serious illness. This is a little different than what docs are being trained for. So in oncology, in adult oncology, there is a huge national program called the STAR program. It's a oncology rehab program that helps people deal with the side effects of chemotherapy. But it doesn't wait for the side effects to occur. There's a whole thing called prehabilitation. So it is intervening before side effects occur so that you minimize the side effects. That's the embodiment of palliative care. So we want to manage the side effects, manage complications in ways that are fine-tuned to the individual patient. We have planning for goals of care. That's not talking about limiting care. It's making sure people understand what's involved with the care, what are your goals, and what happens if we hit a detour. What are your wishes as a person? The most important thing above all with palliative care is to relieve suffering. And I got to tell you, you would think, now wait a minute. Docs, no matter how big their ego, should be able to do that. Guess how much training we get in medical school about symptom control? The most nationwide is a school that gives you 2 days. Most of us get a day in pharmacology, which is kind of buried at the end of the first year when you're exhausted and you still smell bad from gross anatomy lab. That's when they give you a lesson in symptom control. So it is not intuitive to most docs. And when we talk about facilitating a transition to hospice, nobody likes to talk about transitioning to hospice. But if hospice is going to work its magic in terms of providing an ease and an experience with death that honors the spiritual wishes of the patient, and equally important, prepares the family to be survivors, hospice needs about 3 months. Average length of stay on hospice is less than 3 weeks nationally. So we got a long way to go. Not talking about stuff doesn't make bad things not happen. Many times it makes things worse. So when we talk about relieving suffering and distress, people think that we stop at just physical suffering. And that's one of the big differences with palliative care. It's not just about taking away the physical pain. There's emotional pain. There's the disappointment of the things that you can and can't do. And then there's spiritual distress. I can tell you that even in faith-based medical schools, spiritual distress is mentioned kind of at the end of the week on the 4 p.m. Friday class that half the people skip, if it's mentioned at all. And yet, spirituality is an important part of all of us and deserves to be addressed. The other important part about palliative care is that the doc is not the most important part. The doc has to lead the team, but it is a team. If you're going to be certified by the Joint Commission, which kind of gives our licensure to hospitals and all of that, if you're going to be certified by Joint Commission, this is your team. A physician, a nurse practitioner, an RN, a social worker, and a chaplain. And if yours is not a faith-based institution and you want to be certified in palliative care, you still have to have a chaplain. So it's a different approach. A couple of, actually about 18 or 19 months ago, the Institute of Medicine had a report that was commissioned by a public-spirited donor, which they entitled Dying in America. And again, I have to apologize for my colleagues that are focused solely on the end of life, but they wanted a snapshot as to the current state of end-of-life care with respect to delivery of medical care and social supports, patient, family, provider communication of values and preferences, advanced care planning, which is another way of saying how many patients are getting care that they don't want, healthcare costs, financing and reimbursement, and education of health professionals, patients, loved ones, and the public at large. So the healthcare costs and financing, you say, well, so it's all coming down to the dollar. Well, I got to tell you, doctors make their living, they pay their mortgage by turning doorknobs. You get paid on production. And we are only slowly starting to come into a payment system that pays us to take care of people preventatively. Before I had all this gray hair and I was, just starting in medicine, we got zero reimbursement for well child exams. It was considered optional. They only paid for illness. We've come a long way. There's a long way to go, but CMS has now instituted a code by which doctors can bill, get credit for, get paid for advanced care planning. So you get paid for your time. And so it now all of a sudden becomes something that is not charitable work, but it's professional work and it's part of your day. As I said, palliative care is really misunderstood. The stupidity of the death squad nonsense that flew around several years ago didn't help. And we're never going to overcome all that mythology in an exam room. And so part of the outreach are gatherings like this, where we have the opportunity to engage in discussion so people understand what palliative care is really all about. That report came out with 5 recommendations. First and foremost, an emphasis on patient-centered and family-oriented palliative care. Now, in its true form, this is a step back to taking care of the whole patient. And it is a step against the ever-increasing compartmentalization that has occurred in medicine as people become more and more and more subspecialized. Clinician-patient communication, doctors all think they communicate wonderfully. And we know that that's not necessarily true, but it becomes most important when it comes to advanced care planning. Professional education and development. We really need the people that control graduate medical education to recognize that people need to be cared for in a holistic fashion and change the requirements and training programs to include the relief of suffering, physical, emotional, and spiritual. Policies and payment systems have to change, and we need to be part of that, and then public education and engagement has to occur. I do want to draw some distinctions between palliative care and hospice. All hospice patients are palliative care patients, but all palliative care patients are not hospice. Hospice is a very specific designation. And in the United States, you have typically a 6-month benefit. So the doctor has to use his murky crystal ball and say, yeah, I think this person's going to die in 6 months. Well, everybody's afraid to have somebody live close to 6 months, so they wait until death is really imminent and they die in 2 days. It's a mess. But there are regulatory limits imposed, not only by Medicare, but by certain states. Anthem, on a national basis, wanted to extend the hospice benefit to 12 months, and they could not because of the number of states that prohibit that designation for more than 6 months. So it is a very separate designation. But palliative care, you're just kind of another person in the list of people that are treating the family. You say, do we really need somebody else? And the answer is, for better or for worse, yes. You need a team. You don't just need another doctor. You need a team. And I'll use myself as an example of the compartmentalization that's occurred. So I have congenital heart disease, and I have a defibrillator. So when I went to get my stress test before my defibrillator was implanted, my blood pressure went up, and it went up really high. Now, on every other visit to my doc, I had never had elevated blood pressure. But all of a sudden, I have what's called exercise-induced hypertension. So to be an electrophysiologist, that's the people that implant this thing, okay? You have to graduate medical school, go through an internal medicine residency, go through a cardiology fellowship, and then do an electrophysiology fellowship. So I'm in the exam room, the doc is talking to me about my stress test, and I said, well, what about the blood pressure? And he looks at me in all seriousness and says, oh, well, you got to go to another doctor for that. I don't do blood pressure. You're an electrophysiologist. Those electrical signals create my blood pressure. No, I don't do it. That's what's happened to medicine. And in the process, emotional pain, well, that's a psych consult. Spiritual pain, they don't even recognize it. And so that's really what a palliative care team brings, is the recognition that we as people, as human beings, suffer on many different levels, and we have the right to have that suffering addressed. So palliative care, if you look at a palliative care evaluation in a chart, there's a list of all the medical problems and all the things that we're going to address medically. There's a list of the emotional and social issues. Which child has been living in Aruba for the last 15 years and has great guilt that, he's ignored his parents until now? And then there's the spiritual issues, the spiritual questions that come up. And we all have them. The great thing about working with kids is they don't have any filters. They have a question, they have something that's bothering them, they just kind of wander in. Now, sometimes we as adults aren't prepared to deal with it. But I had this little 4-year-old or so, he's tooling around my office. We have a very informal office, and he pushes his IV pole in next to my desk, and he says, "Dr. Bob, I got a question." "Okay, what is it?" Well, he crawls up on my lap, and he's got these big eyes, and he goes, "So why do you think God hates me?" And I said, "Well, I don't think God hates you. Why do you think God hates you?" And he said, "Well, he let me get leukemia, and it upsets my mom, and it upsets everybody else, and I didn't do anything bad that I know of. So if something this bad happens, somebody must hate me." So if a 4-year-old can have that level of distress, think about how complex it becomes when we add in people's egos. And yet we all have the right. It took me 3 years to answer his question, because I had to build his spirituality back up on a developmental basis to reinforce the spiritual teaching that he was receiving from his parents. But adults have far more complex things that we all keep hidden. We don't talk about it, and yet it causes us distress. When we talk about goals of care, get out of your mind that this is about saving money, because that's not our intent. The New York Times had a great article a number of years ago, How Doctors Die. We die very differently. The reason we die differently is that we really understand what all this mumbo jumbo is. We know what all these side effects are and how bad they can be, and we make a value judgment as to what's regular care, what's extraordinary care, and what we really want to do with our lives. And we do things differently. So I told you I have a defibrillator. So once I took this position, I started getting invited to different specialty meetings. So there was a heart failure dinner. That's how they had it listed. They serve salmon at the dinner. And in the process, they're talking about congestive heart failure, and there's this old algorithm that everybody follows. It's about 18 steps as to the progression of heart failure. And somewhere around step 6 of 18, the path is irrevocable. It's not a predictive timetable, but the heart failure is not going to get any better. And somewhere around 10 or so, one of the treatment options that you have to consider is implanting a defibrillator. Okay, so of course I interrupt and I say, wait a minute. Tell me the consent that you give to these patients that are eligible for a defibrillator. And I kind of get these guys looking at me and they go, who are you again? I said, come on, humor the guy with gray hair. What do you tell patients? And they go through their consent. And I said, that's not adequate. And of course they immediately get very defensive. Well, that's what legal says and risk management said it was okay. I don't care about that. Look at the patient that you are treating. And the thing that you are doing by implanting this $60,000 device is you are virtually guaranteeing that this patient will not be able to die quietly in their sleep. And don't you think they ought to be able to have that as part of their decision-making process? Well, I didn't get invited back to any more of those dinners. But that's really what palliative care is. It's not trying to tell you shouldn't do this. It's making sure you understand what are the real implications for your life. When they say that there's a 30% chance that you're going to have a grade 4 mucositis from this experimental treatment, does anybody know what that means? Yeah. It means that when you throw up, you're going to throw up chunks of your esophagus. So, those are things that we can be a little less graphic when you have more time to be gentle with words, but that's what people need to know, because that's what's in a goals of care discussion. Do you really understand? People say, well, I want every fighting chance. Okay, I get that. But if you enter the hospital with this condition and this condition, if your heart stops and you really want us to pound on your chest, I got to tell you the statistics are that less than 1% of you will walk out of this hospital. You say, well, maybe I want to be in that 1%. And there's no easy answer to that. I have been blessed in my career to have 2 patients that people consider to be miracles, and were evaluated as part of a process. And I can tell you that I didn't have to put 100 kids through torment for those 2 miracles to occur. So I think that there are other ways that miracles occur besides us cracking your chest and breaking ribs and doing all the things we do when you tell us you want everything. It's making sure people understand what fighting and everything really means. Oh, and see if I can go back one. Assisting with integration and coordination of care. If you think doctors don't talk to patients, they don't talk to each other either. So it's very common that you have one doctor doing one thing, one doctor doing another thing. They haven't really conversed, and the treatments are interacting poorly with each other. And again, palliative care not only will assess that, but takes the initiative to talk to the 2 egos that aren't talking to each other and say, you got to fix this. It's not right. It doesn't make us popular, but it's not about a popularity contest. Family meetings. We all like to think that we have the ideal family, but the reality is that there are families that are difficult, and everybody brings into their own baggage. But when you have a serious illness, understanding is key, because you want support for the patient. Okay, more than anything, whatever the baggage was that's in the past, you want support for the patient. I don't know how many of you have seen The Lion King, but there's this scene where Rafiki finally catches up with Simba, and Simba's afraid of his past, and he hits him with a club or something, and Simba says, what did you do that for? What does it matter? It's in the past. We need to adopt that attitude, because you need support for the patient, but you also need to understand that the family will eventually become survivors, and we have to prepare them to become survivors. And if you don't do that, they don't necessarily do as well as they could. It used to be that you had to have everybody fly in, it was very dramatic, it was very expensive. We can now, it's one of the benefits of telemedicine, we can bring everybody in virtually, and literally I can send an invite to your smartphone, and you can see mom or dad on the phone, and they can see you on a computer screen, and it just adds the face as something more human to what is admittedly a difficult conversation. But they're conversations that you have to be trained how to facilitate. And let me tell you, there's no training in facilitation in most medical education. So I do want to talk a little bit about advanced directives. First and foremost, an advanced directive is a gift to your family. Okay, so one of the things I've done for the past many years, to the embarrassment of my children, is I've been an STD lecturer in the area high schools. My daughters thought they were never going to get a date. But that has opened the door to me appearing in some of the senior theology classes where we talk about advanced directives. And I tell all these seniors, I said, listen, you're 18 or inside of 18. God forbid if something happens to both of your parents, somebody like me with a stethoscope around his neck is going to come to you, give you a bunch of gibberish and say, okay, what do you want me to do? And all you see are deer in the headlights, big wide eyes. But their homework is to take that conversation home. And as uncomfortable as these conversations are, it's vitally important. An advanced directive is just the beginning of a conversation. And you've all heard the public service stuff, about it. It speaks for you when you're unable to speak. It only takes effect when you can't make your own decisions. The state laws vary. Sometimes you have to update them, sometimes you don't. But again, the bottom line is the most important thing is that it should start a conversation so that people understand what's important to you as a person. And if there are questions that you have, then you can deal with those questions before it's a crisis. And so you're much more likely to have a good outcome. This is the other document you'll get asked for. If you go to have blood drawn, they're going to ask if you have an advance directive and a power of attorney. You need to know there's two designations for power of attorney. One is for financial and legal matters, and one is your healthcare proxy. The healthcare power of attorney does have the right to override your advance directive, making a conversation more important than ever. The last thing I would just tell people to consider, there's no real easy form for this, but you can generate what's called a HIPAA release. So if there are people that are important in your life that you want medical information dispensed to, you can give that permission ahead of time, and it can be part of your record. Sure.
Can you have your POA be both of those, like financial, my amount of POA is financial plus she's medical?
Yes. The question is, can the same person be have power of attorney for both financial and for medical? Yeah, the answer is yes.
Two forms, or they just scribble it all in one?
Most of the time it's two forms. There are some states that mandate that it be two forms, and there are some states that you're allowed to combine them, but the language really, so you take two 4-page forms and you make one 9-page form. So I want to get to the crux of what always comes up, and our feeding hydration always required. Understand that I'm talking about feeding and hydration in the context of a seriously ill person who can't feed themselves, who can't drink, and who has ongoing medical problems. And in that context, nutrition and hydration are treatments. And so you are obliged as a physician to evaluate nutrition and hydration as you would for any other treatment. What is the benefit that you hope to achieve? What are the risks to the patient? And then you make a recommendation. And this is from the ethical and religious directives for Catholic healthcare institutions. And people go, yeah, but really, you got to feed people, you got to make them drink. And so my question to all of you is, how many of you, if you saw somebody drowning, would hold their head underwater? I don't see any hands going up. You cannot list out every possible medical condition that can occur. It's impossible. Even if you could, nobody'd read it. What you want is an understanding that when your body is shutting down, don't do things that are going to increase my suffering, and don't do things that are useless. So if your body can no longer handle the fluid and can't process it, it is harming you. And there's a significant number of elderly who you are literally drowning them when you give them IV hydration. Similarly, if you have an intestinal blockage or any one of 200 other conditions, your body cannot use the food, the nutrition that you're putting in either by a G tube or an NG tube or however you're putting it in. The body can't use it. And in those circumstances, it is not necessary to continue it. The ethical and religious directives are very clear about this. They caution against two extremes. One, you cannot intentionally cause death by euthanasia. Okay? So this is not, okay, Grandma, it's time to die, we're just going to cut off everything. That's not allowed. Okay? But similarly, what doesn't have to happen is here you are with whatever condition is causing you to literally gurgle with every breath, and we now have to give you fluids on top of that and make the gurgling worse and increase your air hunger and deprive you of more oxygen? No. But those are the circumstances where the greatest misunderstanding occurs. And again, if you take a step back and you've had the conversation and you say, what I want you to do if I can't make the decision is respect my life so that you don't take it prematurely, and don't do anything that's going to make me suffer more than I'm suffering. And with those overarching discussions, we could eliminate 99% of some of the issues we have with families when huge misunderstandings occur. Because, if the person that has power of attorney says, do everything, and yes, I want hydration, and you explain that this is bad, and they go, no, I want it, I got to do it. Legally, I have to do it until I go to court, and a court says, no, you don't have to do it. It's just, that's the last thing you want. But again, I want to emphasize, this is not about telling somebody, I'm tired of cleaning your diapers, so I'm just going to clamp off your G-tube and we're just not going to feed you anymore. That's not what this is about. This is about when your body cannot utilize what you're trying to put into it. You have no obligation to continue that. A question came up in the previous group, and it's a good example. So it was a man's brother who had bladder cancer, was treated, and the cancer came back and spread. It spread to his liver, spread to his lungs. And then he developed an infection, and the recommendation was don't treat the infection. And that's perfectly all right, because what they didn't tell him that was implied is that the death from which was imminent, by the way, I talked with him afterwards, from the amount of disease in the liver. A liver death is a miserable death and would certainly have increased suffering. And plus, in those circumstances, you get rid of one infection, more tend to come back. So you're not obliged to treat everything that is treatable. So the ethical and religious directives, which in a faith-based institution, I got to tell you, we live by, okay? And it's not hocus pocus, and it's not just, we live by these, okay? And there's a distinction between ordinary and extraordinary care. And this again comes back to the art of conversation, because when I started in oncology in 1980, if a parent refused chemotherapy for their child, we would tell them that's not a good idea, but that's about the limit of what we could do. Today, 85% of the kids that walk into my office with cancer will walk out cured. So guess what? I'm not allowed to have a parent make the determination that they don't want chemotherapy. I'm obliged as an obligatory reporter to call Division of Family Services, and the courts have to decide in this particular case, is the chemotherapy ordinary care or extraordinary? The same is going to occur across a broad spectrum of medicine. How many of you have seen the ads for nivolumab, Opdivo? The lung cancer thing that it says you have a chance to live longer, and there's banners going across the skyscrapers. Nivolumab is a revolution, not that particular drug, but that class of drug, because it targets a specific mutation in the cancer. And these targeted therapies will take someone that is near comatose and in a very short period of time, less than 2 weeks, return them to almost full function. But you notice that nowhere in the commercial does it say you're cured. It just says you're going to live longer. So eventually this drug is going to fail. We're just starting to get our brains around the fact that in many cases when they fail, it's a very steep downhill slope. And there was a case that was published in the New England Journal of Medicine about a woman that had 4 go-rounds with targeted therapy. The scale they were using was 0 to 4. 0 is normal activity, 4 is comatose. Her functional scale was a 3. She got this treatment targeted at the mutation. She went back to a 0. She went back to work. Stayed at work for months. It recurred. They found a different mutation. This cycle occurred 4 times. After the 4th time, it recurred again, and they found another mutation, and they had an experimental drug to treat it, and she declined. This part was not published, by the way. She declined because she could no longer take the emotional roller coaster of going from near death, saying goodbye to her family, and coming back and living for some period of time, knowing that ultimately she was going to die. So it adds importance to the conversation. We've become a society of 140 some odd character text messages and tweets. This is not what this needs. This needs a conversation so that things that are done appropriate to your wishes. It's important to have the conversation, understand the treatments, and have a backup plan. We used to say, have a plan B, but we had a palliative care doc who was in a nursing home and kept talking with the patient and family about plan B, plan B. And this one family member who was only paying probably 10% attention couldn't understand what emergency contraception had to do with her 86-year-old grandmother and complained to the bishop about it. So I've changed my slide to reflect backup plan. There are, Brittany Maynard, I think, was a very tragic case. That was a young lady that moved from California to Oregon so that she could commit suicide. And, the aid in dying people say it's aid in dying, it's not suicide. It's suicide, folks. And this pain is really what drives that, the fear of dying in uncontrollable pain. Again, let's go back to medical education. You know how much training I had in pain control in medical school? 0. In my residency, 0. In my fellowship, 1 day. So as physicians have acquired the training needed to provide good pain control, this becomes less and less of an issue. There are those rare circumstances where pain is absolutely impossible to control with standard therapy. And the example I always use is this little guy that I had. He was under the age of 5. If any of you had surgery and I gave you between 2 and 4 milligrams of hydromorphone, Dilaudid, you'd be happy for hours. He was getting 100 milligrams an hour IV and was still in pain, so much pain that his parents couldn't hold him. And I went to his house and he said, Dr. Bob, I just want my mommy and daddy to be able to hold me and I don't want it to hurt. And I said, I can do that, but you're going to be asleep. And he looked at me, the look that kids give, to adults when they just don't get it. And they said, I will always know when my mommy and daddy are holding me. And so I came up with this cocktail and we gave him what's called sedation of the imminently dying. I didn't stop any of his other meds. I didn't stop his fluids. Didn't do anything except give him some really potent medication. And he died 3 days later, but he spent the last 3 days of his life in his parents' arms. Now, I will tell you that there are docs that won't do this because they're afraid of being accused of euthanasia. And it's a slippery slope. But the intent for this little guy was that his mom and dad were going to hold him. And the intent when this was done on an adult that I know was so that his children didn't have to watch him biting through things because he was in so much pain that he couldn't stand it. And it's a perfectly accepted medical practice because you got to know what you're doing. And again, it's not in anybody's training program.
Doctor, how often does that happen though? What percentage of the cases?
Oh, it's not even.
Medication not.
It's not even 1%. So so I started in oncology in 1980, and in my career I've probably done it 8 times.
Because the other side says to us pro-lifers that they are in favor of assisted suicide because of these extraordinary cases, like the example of the young lady who went to Oregon. She did not want. Nobody wants pain, but there were ways that could have been handled.
It wasn't at that point either. She went on a little trip and she goes, maybe it's not time for me to die. And they pressured her. People think they probably pressured her to go through it so they could have their little poster child.
So there are a lot of, so I'm supposed to repeat, there's this big sign here, it says repeat the questions. So for the recording, the discussions about Brittany Maynard and how often intractable pain occurs at end of life and whether or not Brittany was really in that situation. So intractable pain is rare, but it does occur. But people are afraid. I will tell you that the little guy that I just described, John Ashcroft was the Attorney General, and he had come out with this proclamation that if he thought anybody had committed anything, that doc was going to be in jail. So, you know, you can bet that my documentation was extensive for that particular case. The Aid in Dying group, you know, they're not going to go away because they will prey on the fear that people have of dying in intractable pain. My message to all of you is that the reality is that's an even stronger argument for palliative care. Palliative care makes aid in dying irrelevant. Because if you're under the care of a good palliative care physician, all of the things that factor into that aren't going to enter into your life. It's not even going to enter into the equation. So there have been aid in dying legislative proposals introduced in Missouri. They didn't go anywhere yet, but you know, there's 5 states that allow it and 30 more states that are considering it. And yes, you should certainly rally against that. But I would tell you the more important rally is to the ACGME that controls medical education and say, wake up and mandate that this kind of training is included for our physicians. Our physicians need skills that you are not mandating, and people are suffering because of it.
Can that be done legislatively?
No. The ACGME, because it's a national, I guess it could be done on a federal legislative level. Let me tell you, that's,
You don't want to go there.
oh my gosh. You know, I have been on several legislative lobby days, talk about a fish out of water, but I'm astounded anything gets done. I mean, you know, it's just, so, but ACGME cannot respond, does not have to respond to legislation on the state level because it's a national body. One of the other things that people always talk about with morphine drips and Dilaudid drips, et cetera, is that you can suppress the respiratory effort. And that's a standard complication that everybody talks about. Since 1980, that's the number of times I've seen it be an issue. You have to know what you're doing, and you have to pay attention to the patient. You can't treat a patient according to a formula. You have to treat a patient according to the patient's needs, and sometimes that means that you have to stay by the bedside, or somebody has to stay by the bedside and make sure the dosing is correct. But if the dosing is correct, the patient is comfortable, and there's no issue with respiratory effort, with breathing. I also want to make you aware of a thing called POLST, which is physician orders for life-sustaining treatment. These are medical orders that essentially are taken from your advance directives, put into a form. It's done on a state-by-state basis, and they become medical orders if you're off visiting your kids someplace and something happens and you go to a different hospital that doesn't have your medical record. They're not yet legal in Missouri. I think they eventually will be. All I can say is be very careful, because these become medical orders that will be operationalized. You walk in, once it's legal, you walk in, you show, somebody shows them the POLST orders. That's what the emergency room will institute. I think it's a good thing, because it's a good way to not have the emergency department go through all of their little care paths when they don't know anything about you. It's a good way to communicate when you're in a health system that doesn't know you. But it's just something to be careful about. In Missouri, the only thing that is legally valid is what's called an out-of-hospital DNR, out-of-hospital do not resuscitate. You say, well, why would you need that? Well, if you have a patient who is going to die, and they have made the decision they don't want chest compressions, et cetera, something could happen where they need an acute intervention, pain or shortness of breath or something, whatever, something that is causing them suffering, and people shouldn't suffer. In the past, it was the legal idea was that if you called 911, you were revoking your DNR order. That's not the case if you have one of these out-of-hospital DNRs. It has to be on a purple form. There's all sorts of stipulations about it, but the bottom line is you can call EMS. They will transport you to a hospital that will relieve your suffering, and people will honor your request to not have chest compressions or intubation. So Palliative care is really about defining you as a person, okay, and meeting your needs as a person. I can't repeat enough that you have to start the conversation and have the conversation with your family, with the people that are important to you, so that who you are as a person, physically, emotionally, and spiritually, is known, and people can act with confidence on your behalf. There are going to be ethical questions that come up, and St. Louis, the St. Louis region, is blessed with Mercy and SSM, both of whom have well-trained chaplains, well-trained ethicists, who will counsel you in accordance with Catholic teaching, but again, in a way that ensures that your physical and emotional and spiritual needs are met. So in your packets are some resources. There's a couple of publications from the Catholic Health Association. There's a book called My 5 Wishes, which is again kind of an icebreaker. One of the other things that I have used successfully is a card game. It's called My Gift of Grace. It's 47 cards with a bunch of questions on it. And it's an icebreaker to start the conversation. So like question 13, who do you know who is providing care for someone else? What one thing could you do to support them tomorrow? Question 12, what are you no longer embarrassed about? Question 20, if only one story is told at your memorial service, who should tell it? Again, questions that help define you as a person, and it's a way to start the conversation because a card game is kind of non-threatening. You buy these online. It's called My Gift of Grace, and I don't have any financial ties to any of these people. I forgot to mention that last time. But I don't have financial ties to any of them. They make good products, and that's it. I'll take questions now, but on the front of that envelope is an email address. Feel free to email me with questions. I can't give legal advice, but I can certainly help dispel misinformation, provide information, or refer you to additional resources. And with that, I'll stop there. Yes?
I just have to say thank you. I've been at inside of my mother and my husband, and both were difficult situations, very difficult choices. And my mother called the priest in to listen to what people were telling us, because we wanted to do the right thing. With my husband, we were at Mercy, had palliative care. I was very suspicious of it, because I didn't know enough about it. Very suspicious. And then we had to make some tough decisions. And one was, we taking him off the respirator. He was doing well, and all of a sudden he went back down, up and down and down. And so finally, the decision was made not to put him back on. I won't go into all the reasons why. But then they gradually increased morphine until he died. And even though I talked to my priest, I talked to everybody that said, no, that was the right thing, it still causes me pain. And so I'm not sure.
So the comment is about a situation where somebody is taken off a ventilator, the decision is made not to put them back on, and morphine is administered, sometimes in an increasing dose, until the patient has died. So I really wish that this one patient that I had a long time ago, I wish he had been at a time when it was easier to do recordings, because he would tell you what it was like to be on a ventilator. He had a condition where he was on and off a ventilator 18 or 19 times before he died. And, you know, he said it's worse than the worst bully at school hitting you with a baseball bat, except they're doing it 20 times a minute. And that's what it feels like, except they're shoving the baseball bat inside of you, so you feel like the baseball bat's trying to come out through your ribs. But it was much more dramatic when you had a little squeaky voice telling you that. Not quite as squeaky as the keynote speaker today, but squeaky like that. Medically, the decision is always, what is the goal of this treatment? If the goal of the treatment is that somebody gets to leave the hospital, then that becomes a much more important treatment But in so many cases, as the body fails, as systems fail, it's a losing proposition. And you may buy hours, you might even buy days, but you'll never buy weeks or months. I can't give you the inner peace, in a sentence, but certainly I will tell you that from a medical perspective and ethically, I think you did absolutely the right thing, because if you were offered the option of not going back on the ventilator, that meant that treatment was no longer going to be beneficial. Okay? So, all right, so we've made that. Now what are the consequences of that? One of the consequences, the medical term for it is dyspnea. You're short of breath. Morphine, and this just goes to show you how much we don't know about the human body, more than any other drug, morphine is very effective at relieving the symptoms of dyspnea. So you give morphine specifically to relieve that sense of air hunger, that sense of shortness of breath. Okay, and you escalate the dose until the patient's comfortable. Now, if you've got some process going on in the lungs, ultimately that patient will die, but they will die without being hit on the inside of them with a baseball bat, and they will die comfortable. And with people at their side that, they can see your face and hear your voice without noise of a ventilator or this tube sticking out of the middle of their throat. And when you create memories, so children always make us look like we're idiots, okay? You say, I think this kid's going to die, and they live, and but what's important is what the kids teach you. And so what the kids have taught me is that for those kids where I really thought they were going to die and they didn't, what they remember is the fact that all of the machines weren't there. The people that were important to them were there, and they were comforted by that. And it was a wonderful thing to wake up to. And so a person that's dying is going to have varying degrees of consciousness. But how much more wonderful to support the consciousness with the love of family as opposed to the intrusion of technology. I wish we had a different way to do it, but we don't. We just don't. And so that's the decision that you face. And all of the stuff that was in the background to their recommendation, I'm sure that there was a lot of medical data. But we're not data points. We're people, created in God's image. And at some point, we go back. That's what we believe. And at some point, what we think is helpful really crosses the line to desecration. And so it's always as a physician, it's a difficult conversation to have when you think somebody is crossing the line to non-beneficial care. But I think it's a very important conversation. 20% of the people in adult intensive care units right now, nationwide, are receiving non-beneficial care. If your husband was on a ventilator, you've seen what an ICU is like. That's not a vacation, folks. We do a lot of things that are pretty uncomfortable in an ICU. And we ought to fight like crazy if it's going to be of benefit. But if the benefit is, well, I think this will keep the family from suing me, or it's going to keep, the cousin in St. Thomas happy and quiet, that's not really in the patient's best interest. Yes.
I think, Doctor, you obviously are speaking from a Catholic perspective and a Catholic function. And I think we could have a whole nother day talking about secular hospitals, of course, of which we have many here in St. Louis or elsewhere. who don't have the same perspective as you on these end-of-life decisions. And I have, just this summer, I was at the National Right to Life Convention, where there was a huge workshop talking about 4 different situations of people who did not have family members in town, and how the hospital or doctor's decisions were not in their best interest because they did not have the same perspective, beautiful perspective, and Catholic perspective that you have, and that we all have. How would you address that?
So the question is, essentially, how do we enforce Catholic teaching and Catholic principles in secular hospitals? So first of all, I would tell you that, as I said, for a palliative care team to be certified by the Joint Commission, you have to have a chaplain, and that's the first line of defense. The second line of defense is to have an advance directive that is as explicit as possible. If all you do is you check off the boxes, it's better than nothing, but only a little bit. You know, there's a place on an advance directive for a narrative, so you can discuss the things that are important. Missouri Catholic Conference has an advance directive that's a Catholic advance directive, and it's valid. It's certainly valid in Missouri. I don't know about other states, but it specifies, I want a priest on there, you know, so but you don't have to have a thing from the bishops to do that. You can put that in your own advance directive. Put it at the top of the list of the narrative. When I am seriously ill, I want a priest and I want the sacraments. The third thing, I would just tell you to just be a little careful of examples, because our memories are created from exceptions. But care has become so complex that I would be cautious about generalizing that. That's not to say bad things don't happen. I mean, you know, I happen to personally know, I don't know how many of you remember when Barnes was on the front page of the Post-Dispatch because they transferred somebody to City Hospital that had been stabbed and the knife was still in his back while they transferred him, you know. People make bad decisions. We're all human, you know. But the best defense is to have someone who's going to be a strong advocate and who's willing to say, you know, in those circumstances where the family's out of state and things are being done against their will, call up and ask for the risk management team. That'll get people's attention, because if risk management shows up, it means somebody's thinking about a lawsuit. You know, so there are a number of ways around it. It always helps if you've had somebody that's guided you locally, even if you're dealing with somebody at a distance. You know, when my folks were living in Florida for a while, and my mom was in the trauma center getting a knee replaced, and her care down in Florida, and her care was horrendous. It was so bad, I flew her via Arch from Melbourne, Florida, back up to St. Louis. And they had let her skin deteriorate so much that St. Louis put her in the burn unit. So I wasn't going to sue, but I knew all the right terminology and sent a thing down to their Vice President of Medical Affairs. I had people calling me for the next 3 weeks. You know, you can impact things, but you do have to know the language, you have to know the jargon. If you've had a conversation about things, you start to learn the jargon. And those are the best defenses. There's nothing that's going to work 100% of the time. Be careful of the exceptions, learn from the exceptions, but don't let the exceptions create unreasonable fear.
Thank you.
Yes, I'm sorry.
I think one of the times was actually in the hospital, but people that my children know, my children are adults now, people that maybe are in their 50s go to the hospital with like heart attack or brain damage, sometimes there's parts and brain injuries. Well, the first thing that the doctor comes in and tells them is like, you know, do you want us to operate or do you want us to not do anything? And they kind of talk to people into not doing anything, and they don't do nothing, and people die, and you know, know, it's like, my family member at the very beginning discussed it, very disgusted with the hospital that just got people to die that.
Well, so the question is,
The other one that they did help, even though they were kind of pushed not to, and they're surviving, they're, living life, It's like,
so the question is about, catastrophic events and when you're faced with the decision of how much you do. That's always, that's a lose situation. Because the person survived and lived life just, is living life and presumably with some quality. I can tell you of 4 people that I know that really had heroic measures done, and that's bankrupted their family, and they have no quality of life. They don't even know that they're alive. But once you reach a certain point, basic life functions are going to continue for years. So it is as somebody who has worked emergency rooms, I will tell you, it's your best educated guess with a murky crystal ball. I remember to this day an 8-year-old that was brought in having been pulled from the bottom of a pool. Well, it was May, okay? So the water was a little cold, and they were from way out. So they had already been resuscitating him for 35 minutes and had nothing back in 35 minutes. And so, I made the decision to warm him and continue the resuscitation until we got him warm. And then when nothing worked, then I called the resuscitation off. There were people that were very critical of that decision because for what his core body temperature was, people thought that 35 minutes of resuscitative efforts were more than enough, and that I took an unreasonable risk. This wasn't the family, this was professionally. People thought I took an unreasonable risk of creating a devastated child inappropriately, and so there are many cases, where you just kind of look and you go, I don't know if this person can recover or not. I think the answer is no. But if you want us to try, we'll try. It's that balance of trying to give full disclosure and not give false hope and not provide non-beneficial care. It's a pretty slippery tightrope, and I'm not going to say people are going to walk it perfectly. Yes.
For a person who has had diabetes for, say, 20 years and then goes on dialysis, would that be a good example for someone who could benefit from palliative care?
Yes.
I'm having trouble understanding.
I think that anytime you have a chronic, so the question is, someone who's been a diabetic for 20 years and then goes on dialysis, is that a good person for palliative care? Anybody who has a chronic illness should eventually see palliative care, just so that you can understand what the options are and what the side effects are. I think that dialysis in the context of diabetes is certainly a very common event and one that doesn't carry a lot of risk, but there are other issues that can occur, and people should at least know about that and decide how they want those handled. So yes, and there are some endocrinologists that have become good at doing that, but if, again, people shouldn't be afraid to say, I don't get what you just said to a doctor, and if they still don't get it, say, we need an interpreter in here. Even though we're all speaking English, I need an interpreter.